Afternoon, everybody, and welcome to our COVID-19 Children Seminar Series. My name is Alan Schroeder, and I'm the co-chair of this series along with Rajni Matthew. Thank you for joining. I know there is a lot going on today, and people are distracted, so hopefully you can turn off your news networks and shut down your spreadsheets and think back to COVID for a little bit during the next hour. We have a really exciting session to talk about some important and controversial issues, but I will let Dr. Matthew introduce Dr. Maldonado, who is our speaker today. Just as a quick reminder about the series and where we've come from, this is our sixth session today. We have gone over a number of topics relating to the pandemic and kids, including sessions on vaccines, sessions on schools, sessions on the primary care perspective, and then kind of a deeper dive into virology, as well as an introductory session with a panel that included Dr. Maldonado and Dr. Prober and Dr. Pizzo. I have covered the gamut and have some really interesting upcoming sessions as well. On the November 12th, we will have Carmen Powell and Kim Hong talking about COVID and the impact of some of the health disparities we're seeing and racism. And then after that, on November 19th, Hayden Schwenk, who has been leading, along with Dr. Matthew and Dr. Maldonado, a lot of our COVID efforts at Lucille Packard, will talk about the therapies that are being used. With that, I will pass it along to Dr. Matthew to introduce Bonnie.
Thank you, Alan. Good afternoon, everyone. It's my pleasure to welcome Dr. Maldonado back again with us. Before I introduce her, I just please put your questions into the, did we say chat box, Alan? Can you remind me? Is it?
Questions in the Q&A.
Q&A. Please go ahead and put your questions in the Q&A. Today's topic is obviously of great interest. And so please feel free to put in your questions, and we will do the Q&A after Dr. Maldonado's presentation. I'm going to provide a brief introduction to Dr. Maldonado because all of her work, her accomplishments, her awards are too many to count at this time. But in terms of brief introduction, she's a professor of pediatrics and professor of health research and policy, and serves as the senior associate dean for faculty development and diversity at Stanford University School of Medicine. She's the chief of the division of pediatric infectious diseases. She's been since 2008. She's also the chair of the Red Book Committee, which is the American Academy of Pediatrics Committee on Infectious Diseases. Dr. Maldonado's research activities have included studies on epidemiology, diagnosis, and prevention of various viral infections. And now, more recently, over the past year, she has been leading a lot of COVID-19 research work in understanding prevalence, transmission of the virus, as well as therapeutic trials, and more recently in the realm of vaccine trials as well. So obviously extremely proficient in COVID-19 knowledge and expertise, and is here to talk to us about transmission and epidemiology in pediatrics. Thank you, Dr. Maldonado. I will hand it over to you now.
Thank you. And I see my dog decided to join me in the background there, so sorry about the
problem.
Yeah, I wanted to, thank you so much for that introduction. I think I know, we all know each other quite well now. So let me pull up my slides so that I can share them with you. I was given a number of different topics to cover today, and I want to be able to cover some epidemiology, but mostly deal with some issues that keep recurring and deal with them in a little more depth today. So feel free to add questions to the chat box, and Rashni, if you have questions, you can feel free to interrupt me as we go through. Let me start off by talking about the objectives today, I'm going to really just do a very brief overview of the current epidemiology of pediatric COVID-19. As you probably know, the American Academy of Pediatrics has every 2 weeks, we have an update of all of the data from around the country. And so I'll go over that. I'm going to spend most of my time really talking about respiratory versus aerosol transmission. I know people have had a lot of questions about that, and I just wanted to give a little more of a deeper dive into what that means. And then what we know about masks, just again, a high level overview, and then just a refresher on what we talked about, I talked about before for some of you who were on, just around what we know about daycare centers, and then a new review that came out on Friday about household transmission. So hopefully we'll be able to touch spaces on most of that in the next 40 or 50 minutes. So if we look at the, this is the AAP report, and you can go to aap.org, and right on the very top of that website, there's a link to the COVID-19 section, and you don't need to enter your member number, because I know it's always a hassle to get into the AAP website because you have to remember your member number, but you can just jump right in, and then down at the bottom right of the COVID page, you can get a link to this whole report. If you want to see the whole report, it's about 30, 40 pages long, and you can look at different data from different states. So this is just a summary, and the AAP, along with the Children's Hospital Association, started to put this data together in July, and they actually track it all the way back to the beginning of the pandemic, and whatever data each of the states and regions of the US have been putting up on their individual websites. So they just basically collate what all of the different states have put together. And it's a really nice reference, because there's nowhere else where you can find US data on children other than this particular report, which is unfortunate, but they fortunately are now keeping it up on a regular basis. So you can see here that so far in this pandemic, since the beginning of reporting, probably most likely in March or so, some states in April, we are seeing over 750,000 children who have been reported to have COVID-19. I'm sorry, overall representing 11% of all the cases, and that percentage has been going up little by little over time. It had been hovering a little bit under 10%, so it's going up, but it's not going up astronomically. The overall rate is also per 100,000 kids is also going up. It had started off around half of this number, but it's now about over 1,100 children per 100,000 in the population. And this is age adjusted. Now, in terms of the change, they also track the rolling change over time. And just so that we know that in October, there were nearly 200,000 new cases reported during that month. So quite a big jump. And in the 10 states that actually report age-based testing data, so it's not a lot of states, but when you look at the testing data, children make up between 5 and 17% of all the total state tests, and between 3.5 and about 15% of the children are actually testing positive. We don't have any information here around symptoms at this level. When you look at hospitalizations, so this is only 24 states that report age-based hospitalizations, and New York State does not, but New York City does. And so it's 24 states in New York City. And in those states, children were between 1 and 3.5% of total hospitalizations, and between 0.5 and 7% of all child cases resulted in hospitalization. So again, still low, relatively low numbers. They are creeping up a bit, but they're still low. They had been all under 5% until recently. And then mortality data from 42 states that report age-based mortality, as well as the city of New York City. Children represented 0 to 0.2% of all COVID deaths, and the actual number is 121 kids. 16 states reported 0 child deaths, and overall, from 0 to 0.14% of all pediatric COVID cases resulted in death. So again, fortunately, we are still seeing low numbers around the country. And I don't have specific epidemiologic information beyond this in terms of, for example, how sick are the children? Are they ventilated? What is the risk factors? But we have anecdotal information. I actually have every other week I meet with my Red Book committee. We generally only meet twice a year, but now we've been meeting every 2 weeks. So we just met this morning. We go over what everybody on the Red Book committee has been seeing in their own region and talk about different issues around COVID and kids. One of the things that we are going to talk about that you might see in the next few weeks is we are starting to relook at our school-based guidance. And so far we have not changed our AAP school-based guidance. We still think that the guidance is the same. I think what has changed is that since we put that guidance together, we actually unfortunately wrote it up in June, May and June. It got posted right before the July-August surge. So people were worried that we were saying children should go back to school. And I know I've been quoted out of context saying that all children should just go back to school. What they don't say is the next thing that I said is if it's safe for them to do so. So, and I've been getting a lot of emails about that, and I still stand by that fact that if it is safe for kids to go back to school, they could go back. But in some states, for example, surges are happening and it may not be safe because there aren't enough precautions being taken at the schools or in communities to be able to make sure that kids are going to not bring disease into the school, because most of the disease is coming from the neighborhoods and the communities. A lot of it is household transmission. A lot of it is family gatherings. So that's what I'm hearing from my public health colleagues all around the country. And so, but there are places where kids are going back to school in hybrid models, and mostly in hybrid models. And unfortunately, there's a disparity there, because what we're seeing is kids who are coming from private schools who have more resources are actually more likely to go back to school, whereas kids from public school districts are not as likely because they don't have the resources. So anyway, so that's the update so far around children and COVID. We will be seeing some sports guidance coming out as well. There are no new data around what to do with sports, and people are concerned because with the winter coming along, especially outside of California, most of the activities are going to be indoors. And the question is, should we be allowing children to practice indoor sports? And we are very conflicted in the AAP because we don't know whether we should even be advocating for sports on an indoor basis right now, given what we know about what I'll talk about later around transmission. And the question of whether children should be wearing masks while they're playing sports if they're indoors. I think everybody feels reasonably comfortable that if kids are outside playing sports, they don't need to wear masks, but the question is in an indoor basis. And there's no consensus around that issue. So that may come up in your neighborhoods and your pediatric practices as well. So I wanted to spend most of my time talking about a scientific overview that finally was published by CDC. We've been talking about this since March here at Stanford and elsewhere, but CDC has put together a nice little brief that I'm going to summarize for you here, and you're welcome to take a look at it in more detail. But really talking about this issue around what do we mean by airborne transmission and how important is it for transmission of this particular virus? And I have been following this literature and the work of some of my colleagues at different institutions around the country for some time now. And so this is a really helpful little review. So we are absolutely, from an epidemiologic perspective, and I agree with the CDC on these things, I am absolutely convinced from what the data that we see here at the hospital, what we're seeing around the country and around the world, that the principal mode of transmission of this virus is through exposure to respiratory droplets, not through aerosols per se. Although not to say that airborne transmission doesn't occur, but it's a very specific situation or situations, and we'll come to that in a bit. So when we say exposure through respiratory droplets, we are talking about things like basic things like breathing. So if someone's breathing or speaking, singing, coughing, or sneezing, you've seen that classic picture of the person coughing or sneezing. It's really disgusting, but you can see all the little droplets of saliva spreading all over the place. And that's what we mean by respiratory droplets. There are all kinds of sizes. Some of them you can just see with your naked eye. Some you need to see with other mechanisms. But because they're so large in general, these droplets are just going to move and drop right to the ground. They're not going to go very far. And of course, the harder somebody sneezes or coughs or speaks, the farther the droplets can go. And so I think some of you may have seen that there was an outbreak in Europe in a yodeling class. So people were taking a yodeling class, and there was a mini outbreak within the group of people who were taking yodeling lessons. And you can imagine that if you're sitting there yodeling into a room of other people, that there could be transmission of droplets. So that's what we mean by respiratory droplet transmission. Most of those are large. Smaller droplets and particles, and by small, I mean less than 5 microns. So we're really talking about tiny microscopic particles. That's what we mean by aerosol. And you can generate droplets as small as 5 microns, but those generally come from alveolar and very lower respiratory tract generation of aerosol. So when you cough, some of those can come up from those parts of the lung. And for example, with measles, we know that measles virus can be sitting in the alveoli. And when those small, tiny, less than 5 micron aerosols pop out, they can carry measles virus, and they can sit, because they're so small, they can sit in the air for minutes to hours, and they might travel on air currents, although I have I'm not aware of any outbreak that I can document that has occurred because of an aerosol being transmitted by an air current. What we have seen are people who have been infected, for example, by measles, who have been in a room where an infected individual was in that room maybe as long as 2 hours before and still got sick. So that is a true aerosol transmission. And so that's the distinction there. So once respiratory droplets are exhaled and they move forward, their concentration decreases from fallout from the air, and they can really just drop off. And so that's just a kind of a high level definition. Now, let's talk about contact droplet airborne transmission. And for those of you who work at Packard, you're very familiar with the signs that Roshni and Amy Valencia and Grace and I have kind of put together over time so that people really know what kind of isolation we're talking about. But here is why we do it. So infections with respiratory viruses are principally transmitted through 3 major modes. And sometimes they can happen with all 3, and sometimes they can just be one or the other. And keep in mind that we are really talking about children, not adults, because for some of these, behaviors are very important, and adults can control their secretions better than children can. So we are actually a little more conservative in the way we conduct isolation in the children's hospital, because children don't always control their secretions in the same way that adults do. So when we talk about contact transmission, this is really basically fomite transmission. So a child might wipe their hand across their face and accidentally or on purpose rub it against you. And so now your tie or your blouse is covered with whatever was in that child's face and nose. That's contact transmission. And that's why, even though in adults, for example, RSV is a good example. RSV is really a droplet transmission disease, but and then on the adult side, you'll see that for RSV, they generally don't use contact, because adults generally, they won't wipe their face across their their hand across their face and wipe you with it, but children may inadvertently or purposely do that to their healthcare team. So we actually would like coverings. So basically gowns and gloves for contact droplet transmission for respiratory viruses, even though we know that they are droplet transmissions because again, of the likelihood that a child may spread something to you by fomite. So droplet transmission traditionally is just spread directly, as I said, from the droplets, landing on your face, landing on your body somewhere. You might touch that area and then bring it up to your face and then infect yourself. Now, while we talk about 6 feet, 6 feet is really based on epidemiologic evidence that most people have not been infected when they have been outside of a more or less a 6 foot perimeter of an infected individual with a number of different diseases. Some of you may have seen literature from environmental engineers showing that, yes, look, if I sneeze or cough hard enough, that droplet can travel 13 feet. Well, that's true, but we're talking about on average about 6 feet. So on average means that there are going to be a lot of droplets that fall 1 foot or 2 feet or 3 feet. Most of them are going to be very close. If you get to 6 feet, you're very rarely going to see transmission of droplets occur unless somebody's really working very hard at a cough or a sneeze, or if they're yodeling or singing. So we generally think 6 feet has worked. And more importantly, from the epidemiologic perspective, we have seen that 6 feet has worked really well in our case definition for determining exposures. And then finally, when we talk about airborne exposure, I think I mentioned that to you already. These are spread through these very tiny, tiny particles that are sitting in the air. And eventually the particle itself will evaporate. The viral particle may sit in the air for with that particle for some time, but generally after about 2 hours, they will fall to the ground. This is why when we have a TB case or a chickenpox case or a measles case, we try to keep those cases, if they need to go to the CT scan or the MRI room, or they need to go to the OR, we try to schedule them as the last case of the day, because we then need to shut that room down. That room needs to be shut down for at least 2 hours in some cases for TB, measles, and chickenpox, because we know those are absolutely airborne diseases. And we like them to sit overnight, and then we do a terminal clean at the end of at least one shift, just to make sure that all those little aerosols have reached the ground. Because if we clean before then and the aerosols are still in the air, there's still a risk that those aerosol viral particles might land on a clean surface and then potentially infect somebody. So we don't think I mean, we are being very conservative there, but that's the rationale for TB, chickenpox, measles in particular, being at end of day cases where we shut the room down and don't allow other patients in that room for at least a couple of hours. Now, when we look at droplet transmission, we are talking about a whole array of sizes of droplets. And airborne is really very much, again, restricted to very tiny droplets. And these are, particles. And they can also be particles at greater distance or over longer times. And the longer time, again, is because these smaller particles can sit for longer than a large droplet. And as I mentioned earlier, these modes are not mutually exclusive. So close contact refers to transmission that can either happen by contact or droplet when a person is close by, as we said before. Now, as I mentioned, and I'm trying to just reiterate some of this because the literature can be confusing. Aerosol transmission is used in ways that epidemiologists and infectious disease individuals really have very specific meaning for. And when we look at aerosol, we look at these tiny particles that essentially have Brownian movement. They kind of just sit in the air. They move randomly. They might be pushed around by mild air currents, but they can sit for some time. And in healthcare settings in particular, what we worry about in aerosol transmission is really, especially with SARS-CoV-2, is aerosol generating procedures. So for example, intubation and bronchoscopy, where we think, we know that people will produce many, many different droplets of different sizes. So this is not normal coughing, sneezing, et cetera. This is somebody who's being intubated or having a bronchoscope put in their airway, where they are really going to generate lots of lower airway pressure that they normally wouldn't do. And that is going to be generated very close to the face of the healthcare team. That's a very unusual setting that you don't see in virtually any other setting, whether it's a outdoor, non-medical setting, or even in a medical setting, for example, where you're taking care of a crying child in a pediatric practice. In general, that crying child is not having instrumentation being done in their lower respiratory tract where you might pull out virus. And so in these aerosol generating procedures, and as you know, Roshni, Matthew, and Grace Lee, and the IPC team have put together a very comprehensive list of what these are. But again, they are very invasive procedures, and they do require distinct controls, mostly, as you saw, cappers, pappers, N95s, face shields, all of that. And that is really because we're dealing with these aerosols that may be functioning as droplets that are going to be hitting your face because you're so close and you're going to be generating lots of them. Now, just so you know that back in the SARS outbreak from 2002 to 2004, there was also some understanding that there may have been sewage system generated aerosol transmission of droplets that contain SARS, not SARS-CoV-2, but SARS, in a Hong Kong apartment complex. Now, we don't really know, and we don't have evidence that that has happened or can happen with SARS-CoV-2. People have been looking at stool samples. Some of our colleagues here at Stanford, Ami Bhatt and others, and Jason Andrews in adult infectious diseases, have been trying to look at how much a viral particle can you find in stool samples. And on top of that, not only how much viral particle can we find in stool samples, but can you aerosolize those, for example, when you're doing colonoscopies or other lower GI tract instrumentation. And so far, there has not been definitive evidence of aerosol generation in those settings. But again, that literature is still being developed, and we have not seen evidence of transmission by that mechanism. But we definitely heard that that was a possibility during the SARS outbreak of 2003. And it may have been that that particular event was very specific to the sewage system that was being used. It was a very large apartment complex where there was a large degree of spillage of sewage and a breakage in the pipes. And so there could have been an aerosol transmission there because of the specific engineering configuration of that particular apartment. So if you hear about that, that's really the one situation that we know about, and it wasn't SARS-CoV-2. It was the original SARS virus. Now, the epidemiology of SARS-CoV-2 indicates that most infections are spread through close contact, not airborne transmission. And this is why we feel so comfortable saying that this virus is transmitted primarily by droplets, because all of the epidemiology, all of what we've seen around the world, not just here at Stanford, but all around the world, all around the US, really does indicate that this virus is traveling and infecting people through respiratory, not aerosol contact. And the reason is that diseases that are spread by airborne transmission have extremely high attack rates that can quickly reach and infect many people in a short period of time. So if you have measles, TB, chickenpox, you are going to see much higher transmission than what we have seen with SARS-CoV-2. So just on the basis of comparing that alone, you can really determine that that the transmission of those true airborne diseases is very different. And so we know that the vast majority of transmissions of SARS-CoV-2, about are coming from respiratory infection. Now, we also know that a significant proportion of SARS-CoV-2 infections, about 40% or so, occur from people who don't have any symptoms at all, and that we know that they can infect other people. So if, in fact, we were seeing spread of this virus, especially from people who aren't infected or aren't symptomatic, we would expect to see considerably more rapid global spread of infection. By now, we would have seen high levels of herd immunity on the order of 40 to 50% or more. Because if 40% of people who are infected have no symptoms, and if they were spreading by aerosol, they would not know that they were spreading this virus. We would be seeing cases where there was no known contact, for example, because you wouldn't have known that you were in contact with an individual who was infected because they had no symptoms. And so all of this put together, all of these data put together demonstrate that this virus spreads really like all other common respiratory viruses. That is within a short range, within 6 feet, and that people that are far away, that is farther than 6 feet, or who enter a space hours after an infectious person was there, are not getting infected. They generally know who their contact is, again, indicating that it's really close respiratory contact. So, however, airborne transmission can occur, as I said, under special circumstances. So when somebody is very close up, those tiny particles can act like droplets, and they can still infect an individual who might be conducting an aerosol generating procedure. These transmission events are uncommon and really are either around AGPs, so aerosol generating procedures, or when somebody is very close for long periods of time in an enclosed space where there is really not a lot of circulation. So something that could basically mimic an aerosol generating procedure event. So in those situations, enough virus might be present in the space to cause infections for people who were more than 6 feet away, or who passed through that space soon after the infectious person had left. But that person had to have been in that room generating these large aerosols for a long period of time. For example, during an intubation or during a bronchoscopy, when the room is still not been cleaned. So that's why we want people to stay out of those rooms for some period of time around people who we know are infected. Now, so what do we do to prevent airborne transmission? Well, it turns out that the good news here is that essentially, given the limited amount of aerosol transmission that could potentially occur, the same things, and even the environmental engineers agree with this. The point of the environmental engineers is they want us to acknowledge that airborne transmission is possible, although we have not proven it to occur, except maybe in aerosol generating procedures. But they have also said that the same types of interventions can be used for both respiratory droplet transmission and aerosol transmission of this virus, not other viruses or diseases, not for measles, not for TB, not for chickenpox. As we know, we still need to do full airborne isolation for those viruses, because we know that the vast majority of infections from those are through airborne spread. But for SARS-CoV-2, because the interventions that we're using now seem to work, we think that respiratory contact precautions are sufficient. These also include social distancing, uses of masks in the community, hand hygiene, and surface cleaning and disinfection. Now, again, separate from the hospital setting, in the general population setting, the normal mechanisms can be useful. In addition, though, we know that ventilation can be important, and avoidance of crowded indoor spaces are especially relevant for these enclosed spaces. And frankly, we don't have good information around ventilation. That is, what are our metrics for ventilation? And I was on a call with the state health department yesterday, and they're going to be working with their environmental engineer experts to give us some guidance around what do we mean by ventilation guidelines. And by that, I think what we're trying to talk about is, can I go to a restaurant can I go into a school during the winter time when we want to start closing the windows and the doors? And we don't know the answer to that yet. The general answer from what we've seen around the world in schools that have been open, for example, in Europe and other places, is that they do close the windows and doors, and people still are trying to keep distancing and masking. But we do want at least some guidelines around what other ventilation precautions can we take. That is, should we be using HEPA filtration in classrooms? We don't know the answer to that. What about the basic ventilation that is used in classrooms? Should that be, what level of ventilation should there be? And that there's something called the MERV factor. I can't remember what it stands for, but it is an environmental factor that is like a typical efficiency metric for filters in classrooms and other rooms. And so we are going to be asking for more guidance, and schools do have some guidance around this. But the question is, should we be using some specific guidelines for what should be used across all schools and what should be used in restaurants, especially as we're now going back to indoor dining in restaurants. So we don't at this time think we need special engineering controls. I did include at the end of these slides, and I'll post them for you, a bunch of references from all around the world of individual situations where there have been indications that there might have been restaurant spread of virus, and it may have been that there was a ventilatory issue, but we don't also know that there wasn't somebody there who had high viral load who may have been, quote unquote, a super spreader. But at this time, we aren't indicating, even in the general community, that we'd practice special engineering controls. So again, just to recap, enclosed spaces where somebody has been sitting for long periods of time, who may have high viral loads, could be a potential risk for airborne transmission. And I'll show you those references. There are not a lot of those instances that we've documented, despite the fact that we have over 40 million cases of virus around the world. We know that the vast majority of those have occurred through the usual routes of no masking, no social distancing, and no hand hygiene. And so I will leave that subject at that point. Now, some critical questions, though, that we still need to understand, for which people are really trying to do studies, but which we really don't have good answers for, are how effective, as I mentioned, are certain mitigations, like what kind of ventilation is the best ventilation, and what masking is the best masking. Now, of course, in theory, you could say, well, everyone should walk around with an N95 all the time, but that's, first of all, not practical. Secondly, it's likely not necessary 99.99% of the time. As I said, we have over 40 million cases of virus in the world, and people are not spreading virus when they're masking with regular cloth masks outside of the hospital setting and staying 6 feet apart. But it would be also nice to know what small proportion of these infections can be acquired from true airborne transmission, and what are the conditions that facilitate that? Do you need to have a certain viral load? Do you need to be exposed for a certain number of minutes or more? What kind of ventilation is happening in those transmission events? And even more fundamentally, we still don't know what is the infectious dose for SARS-CoV-2. That is, how many viral particles do you really need to infect a person? Now, you can do those studies in hamsters, mice, ferrets. I understand now that minks, which are related to the weasel family, are actually good transmitters of this virus, but we don't know that what happens in a mink or a ferret is the same as what will happen in an individual person. And there are people have been talking, especially the people at the UK, at the University of Oxford, they've been talking about doing challenge studies, which I think is very brave. That is, taking known doses of virus and giving them to individual people to see how much virus you need to give somebody for them to get infected. Now, those are challenge studies, so they're going to actually give people vaccine first and then challenge them. But the problem is we still don't know if the vaccines work. So again, very brave studies, and hopefully they'll do those studies after they prove that the vaccines have some efficacy. Now, do inoculum size and route of inoculum affect risk of infection and disease severity? We don't know the answer to that either. That has been postulated, and I'm going to talk about that in a bit. So what do the data say? So we've talked about aerosols, we've talked about droplets. What about face masks? What do the data say? Well, there aren't great data around masks, but I will show you some data that really do support the fact that masks are working. So first of all, we know that N95 masks in a hospital setting where we are doing aerosol generating procedures, we know that by the very definition of what an N95 mask is that filters out 95% of particles. That's why they're called N95s. We have N100s as well, but we don't really use those. Those are very hard to get, and we don't need those in a hospital setting. In addition, very early on in the pandemic, I pulled out some data looking at what kinds of viral particles do N95s filter. And it turns out that the lower limit of protection is 30 microns. We know that this virus is about 120 microns. So it is it's 4 times bigger than the lower limit of the mask filtration. So if you're wearing an N95, you are super protected. If you're wearing it properly, you're super protected from the virus, since it's 4 times bigger than the particles, the limit of the particle that can be filtered by an N95. In addition, these are certified by OSHA and by Cal OSHA, and they have been put through tests to show that they can filter these viral particles or particles of this size. The other thing we know about masks is there was I think I talked about this a few months ago. There was an MMWR report from Springfield, Missouri, demonstrating that there were 3 hair salon workers who were symptomatic with SARS-CoV-2. They wore double masks at work, and they took care of about 140 clients over a 8-hour period of time. And they had very close contact. As any of you who go to hair salons know, you are sitting pretty close face to face with the person who's doing your work. And none of their almost 150 clients actually demonstrated evidence of infection or symptoms, whereas it was known for sure that those 2 workers who went home sick and didn't mask at home infected their family members. So we do have that evidence. Granted, it is one event, but we know that in that situation, these were individuals who did not spread virus to a large number of individuals from where they were close to them, and yet did spread virus to people at home. Now, we also know from the Georgia summer camp, and I'm only providing very high level examples here. We know that there are other case reports of these kinds of situations, but I'm giving you some of the higher end of cases that really demonstrate the point that masks do work. Now, we know that in the Georgia summer camps over the summer, there was a very large summer camp experience where masks were supposed to be used, but it turns out that they were not enforced at all, and nobody was wearing masks. That camp had to shut down within a week because there were hundreds of infections throughout the entire camp. I don't think they were able to identify one source, but there were there was no mask wearing. So we know that the converse is true, that when you don't wear masks, that you can transmit. And we do know that the use of masks can prevent particles from traveling. Now, here's another study from Emerging Infectious Diseases. It was a case control study of the use of PPE and risk for SARS-CoV-2 infection in Thailand. And sorry, I tried to make this table look better than it does, but this is really a slide at the bottom showing odds ratios for infection. And so the odds ratios go from 0.01 all the way up to 10. So this is a logarithmic scale. And so of course, the further on the right you are, the more likely you are to develop infection. So in these particular studies, people who always wore a mask were less likely to transmit, but people who sometimes wore a mask were actually very likely, as likely to get infected as people who never wore a mask. Whereas we saw a significant reduction. So this number doesn't cross 1. So they actually had a 70% lower risk of being infected than the person who said they sometimes wore a mask. So if you're going to sometimes wear a mask, it's the same, at least statistically, as never wearing a mask, at least from this particular study. Often washing hands and sometimes washing hands actually were equivalent in protection. They were 70% protective. So so often sometimes washing your hands and always wearing a mask were predictive of a major reduction, a 70% reduction in infection among people who had contact tracing. Now, again, we also see that greater than 1 meter of distance without physical contact was extremely protective as well. And having physical contact obviously was had a risk for transmission. So this is a really nice study because it involved thousands of individuals who were contact traced in Thailand by the Thai Health Department. Now, here's another study I have to admit, this in full disclosure, this study is not peer reviewed yet, but it came out in medRxiv, and it is looks pretty good to me. But again, I am not the peer reviewer of this study. So this study looked at determining sources of variation within countries of in capita mortality. So they looked at mortality from COVID-19, and they looked at a whole bunch of predictors, which you can see here. I won't go through them all. You can look at this later. I'll have the slides posted. But in a multivariate analysis of 196 countries, they looked at what factors were associated with higher or lower mortality, and duration of infection in the country and the proportion of people 60 or older were positively associated with per capita mortality. However, duration of mask wearing by the public was negatively associated with mortality, that there was a protective effect of mask wearing. Internal lockdown requirements and viral testing policies were not associated in one way or another with mortality, which you would expect because mortality is such a small fraction of all the infections that you're not going to see that on testing. But the association of contact tracing, however, approached statistical significance. So we clearly think that is important. So the conclusions were that in countries with cultural norms of government policy supporting public mask wearing, per capita mortality increased on average by 15% each week, compared to 62% each week in the countries that didn't have those mask wearing policies. So mask wearing is not going to be the only thing that can stop mortality, but remember, mortality is related to many other factors as well, but mask wearing was clearly associated with reductions. So there are data, and I think I'll have to stop soon, but can mask reduce symptoms? Well, one of my fairly close colleagues, George Rutherford at UCSF, and his colleague, Monica Gandhi, wrote an editorial for the New England Journal recently that said, perhaps we are subclinically providing protection for people, or what we call variolation, which is kind of like basically smallpox vaccination, giving people a little dose of virus by wearing masks. And maybe that's why we're seeing less infections in the population, because we are seeing reductions of overall mortality. And it could be that perhaps by wearing masks, people are just getting less viral load delivered to them by the people who are infected and wearing the masks. But they didn't provide a whole lot of evidence for that. That was just a hypothesis on that part. And then there were a number of rebuttals to this, saying that could be a dangerous approach. That is by saying, well, it's okay to go out and be sick and wear a mask because maybe you're actually helping the environment by essentially vaccinating people against the virus. There is no evidence that works. And my view is that the reason we're seeing less deaths, and despite the fact that we're seeing more cases, is just that at the beginning of the epidemic, we didn't know anything about this disease. we weren't masking properly. We weren't taking precautions because we didn't really understand the disease. And we were seeing very high-risk people get sick and die early on because we didn't understand the natural history. It reminds me of the HIV days when the very early parts of the pandemic really resulted in lots of people dying of full-blown AIDS. And we don't see that anymore. And it's not because we have a vaccine. It's because we are testing people, and we know that the vast majority, 90% plus people who have HIV don't have any symptoms at all. And we have in behavioral and other mitigation factors, drug interventions to keep people from infecting others. So I think what we're seeing now is that we have a better way of identifying the vast majority of people who are going to be infected and who don't have symptoms, getting them out of circulation so that they don't propagate transmission. And actually, we're doing a better job of learning how to take care of these patients once they do get sick and come in. And we are actually protecting our higher risk populations so that they are, sorry, I'm moving my cat. We are protecting more of our high risk populations, and they are less likely to now be sick. In fact, we may have infected a lot of our high risk populations early on in the pandemic. So the idea that masks reduce symptoms is unproven, and I wouldn't take that assumption that that's the case. However, masks can reduce transmission, and we know that there's lots of evidence for that. So I will skip the daycare center data. We talked about it just to say that we know that daycares can be sources of transmission. However, they are not the actual sources. They are where people come together who have probably been infected in their communities. And in this particular study from the MMWR from a couple months ago, what we did show was that the staff workers came in infected. They were all infected. 2 of the 3 staff workers that infected these 3 daycare centers were infected by somebody in their household who had symptoms, but who didn't know they were infected. So they came to work not infected, not knowing that the person at home was indeed infected with COVID. And that also speaks to the idea of, should we keep people at home if they're not sick, but if somebody at home is sick, but not known to be infected with COVID? So that's why we should be doing better symptomatic screening. We also know that children did get infected, but they were very unlikely to get sick. Most of the kids had very mild symptoms, if at all. And children did spread disease, although not very often. One case, for example, of an 8-month-old who infected both its parents, and that asymptomatic children could actually spread disease as well. And then I won't go through the household transmission data, except to say that it does occur. We know that anybody in the family can, and I'll send you these slides again, as I said, transmission can occur within households. The estimates vary widely. Kids can transmit as well as adults. Most transmission we're seeing around the country is occurring in household settings, and all ages can transmit. It does appear that younger children are less likely to transmit disease, but they can also become infected themselves. I am doing a household transmission study now, but I don't have time to go over those results, and we are still in the middle of analyzing those data. So I will stop there, and these are all the slides and the references if you want to go back and take a look at those. Thank you so much.
Well, that was great. Really helpful. Lots of questions coming in, and we have about 5 minutes. I just very quickly wanted to make sure that we had clarified something and then ask a question. Very early on the AAP data where you talked about hospitalization rates, I think you said 0.5 to 6.7% was what they reported. And just want to, that could also include the kids that are being hospitalized and getting universal screening and are testing positive, even though they were admitted for a totally different reason, which at Packard is the vast majority of
Everybody.
positives is those kids.
Absolutely.
Yeah. So that's just important for people to know that that may overrepresent the true risk of hospitalization in kids. The question that I wanted to ask, sort of tying together masks and mode of transmission, is it fair to say that if we are genuinely convinced that masks work, that in and of itself is further evidence of a droplet mode of transmission?
Absolutely. I mean, I think yeah, absolutely. Because if masks didn't work, it would be because there was aerosol transmission. Masks
Exactly.
don't prevent you from getting aerosols.
Yeah, good.
Yeah.
I think that's helpful to
Mhm.
Rajni, do you want to try to field some of the questions in the Q&A?
Yes, thank you, Bonnie. That was excellent overview of both transmission and mask wearing. There are several questions about airline travel and the holidays that are coming up. So I think I will try and figure one question so that you can answer that. The question is about how safe is long distance airline travel? And is it true that the air filtration and circulation system in airlines negates risk of transmission? So I think you could probably cover the airline and how safe is it to congregate during the upcoming holidays?
Yeah, so that's a great question. We've been talking to I won't say which airline, but we've been talking to a couple of airlines. They have wanted to ask us our opinion. So yeah, absolutely. The filtration in the airlines, in the airplanes themselves, the cabin is extremely good. I mean, it's probably like an OR almost. They have really good filtration. They filter out the air. Their air exchanges are very high. So you're not going to see widespread transmission in the cabin. The problem is that the airline industry needs to fill that middle seat if they want to be, according to them, they need to fill that middle seat in order to be profitable. And we said, well, okay, there's an inherent problem here, because if you want to be profitable and fill the middle seat, you're not going to fill it if people are afraid to sit next to an infected person. So I don't think the plane itself is going to infect you. It's going to be the person sitting next to you who's infected. That's the person who's going to infect you. So what we were trying to convince them to do is don't charge people for a test. Give them a free test, or give them a discount on a test or something. Maybe give them a discount on their seat if they get a test, something like that. Because the testing of the people getting on the plane is A, going to make people feel safer, and B, going to make them actually safer, because you're going to keep the infected people off the planes. That is the key. So frankly, I haven't gotten on a plane since February. I've been driving to my family in Southern California. Fortunately, they're not that far away. If I had to fly, which, I mean, I'm not saying you shouldn't, I would not sit next to somebody. So I would almost buy a seat next to me, especially if you're going to be on a long flight, because the longer you're sitting next to somebody who is infectious, you can mask, you can do all that other stuff, but at some point you're going to have to take that mask off to take a drink of water or eat something. And so I think that is my concern. The other thing is there's a paper that just came out, and I'll try to find the link. Remind me to send you the link, Rashni, of an airline that a group of people who flew from Europe, from one place in Europe to Ireland. And there were 40 something people on the flight. It was a big plane. So there were only 45 people on the plane. 13 of the people got infected on that plane. And if you see what happened, they were all wearing masks during the whole flight. Everybody was doing apparently what they were supposed to do. The problem is that two of the groups, there were 4 different groups of people on the plane who got infected and that were somehow epidemiologically related. 2 of those groups actually sat together in the lounge without masking before they got on the plane. So it doesn't help you to mask on the plane if you're going to sit together and have drinks or whatever together before you get on the plane. So they infected each other, I assume. That was the link there. And they were on a 7.5-hour flight. That actually outbreak wound up creating an outbreak of over 50 people, because then they went on to their different destinations and infected other people. So the other thing that happened is that people, even though there were 42 people on this gigantic plane, they were all clustered together. So if I were getting on a plane, I would want to sit at least a few seats away. So if you look at the way the transmission occurred, it was very close. You were either sitting right next to the person or right across from them in the aisle. So I think it's safe. I know a lot of people have flown to Europe, to lots of places, and not quarantined for 2 weeks. But if you're wearing a mask, you bring your own food, you clean your surfaces, you try to stay away from anybody sitting next to you. If you have to sit next to somebody, just be super careful about keeping that mask on. And keeping your hands clean and wiping everything down, or seeing if you can just be asked to be moved, or or have it be your family member sitting next to you. So I've traveled to see my family, but we all get tested first, and there's only 5 of us, or less than 10 people together.
Thank you so much, Bonnie. I know we are on the hour right now. There are so many questions and endless discussions that we can have, but I think for now we will close.
Have a good day, everybody. Stay calm.
Thank you.
Take care. Bye-bye.
Bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.